We are dealing with active inflammation like vasculitis, sympathetic ophthalmitis, JRA, Behçet's, viral infections, syphilis, tuberculosis, worms, or the sequelae like the cataract, pupillary membranes, retinal detachments, vitreous hemorrhages, hypotony, or very rarely CNVM because POHS is not very common in India. So what is the role of a retina expert? Basically, to give the diagnosis with the biopsy, therapeutic vitrectomy, or to clear the visual axis, settle the tractional retinal detachment, or do laser for neovascular complications. So this is a 2-month-old premature kid who had a history of hospitalization. You can see these vitreous opacities. The parents came with a white reflex concern. Another patient with JRA was on systemic steroids with an intense vitritis. So we went ahead vitreous biopsy. Can you play the video? Yeah. Thank you. So vitreous biopsy is to take an undiluted vitreous sample and then inject the air so as to avoid hypotony and lens touch. And this is important for the diagnosis. So both these patients turned out to be fungal endophthalmitis. Can you play the video, please? Another patient with JRA with intense exudation in the anterior chamber. The patient has already undergone lensectomy, vitrectomy. This also turned out to be a fungal endothelial abscess. Another common injury in these age group is caterpillar hair injury. They come with just a non-specific injury. They must have just cleaned their face with a towel or dust falling in the eye, but you can see the intense vitritis in these patients, and this was a secondary infection following caterpillar hair injury. This is a patient, 7-year-old, who came after chicken pox 1 month with decreased vision in the right eye. There was a thick epiretinal membrane and intense inflammation which was reduced with steroids, but after 1 month there was a further reduction in vision because of increased traction, and epiretinal membrane was removed, which turned out to be positive for herpes simplex virus. Another patient with obliterative vasculitis after a viral fever. Again, we had no clue because all the tests were negative, but patient had a thick epiretinal membrane. And all the vitreous biopsy still was negative. We were still clueless, but this was secondary to a viral infection following 1 month of the infection. This is a patient with the obliterative vasculitis post-chikungunya. So this can also happen, but these patients do respond well to systemic steroids. This is following dengue. Patient developed this proptosis and panophthalmitis at the nadir of thrombocytopenia when the patient was hospitalized and patient received a blood transfusion. This was a no PLI. We just did a tarsorrhaphy, gave systemic steroids, and patient improved. This is a 16-year-old girl with reduced vision in the right eye with neuroretinitis picture. There were areas of retinochoroiditis which were seen, and we suspected either a toxo or a syphilis. Patient underwent systemic investigation and was positive for VTRL and TPHA. This was a non-HIV patient, 16-year-old unmarried girl. Another 17-year-old boy with intense vitritis. Look at these vitreous opacities which are just above the areas of retinitis. The other eye has healed chorioretinitis, and this patient again was positive for VDRL and TPHA, and patient also turned out to be HIV positive. These patients respond very well to systemic penicillin, and patient recovered 6/6 vision. So syphilis can be a great mimicker even in this age group. Tuberculosis, subretinal abscesses. Diagnosis is slightly difficult in children because most of these patients are Montus positive. They respond very well to the ATT. This is a patient with neuroretinitis. Patient had a history of unconsciousness, extensive fibrosis on the disc, epiretinal membrane. Patient had neuro lesions, enhancing ring lesions on the brain, and this on anterior chamber has cysts. So this was cysticercosis. This is TOXOCARA is another condition where there is a contact with PETs, where you can see a drag disc with exudation. After settling the inflammation, these patients can undergo surgery for the tractional retinal detachment. It's not playing? Yeah, thank you. You can see very fibrous vitreous membranes here. Caution should be taken not to induce retinal breaks, just to relieve the traction. This is the post-op picture which we are seeing. Patient has still on follow-up for 2 years after surgery and is maintaining 660 vision. Again, a classical picture, outer retinal opacification. This is acute retinal necrosis. This was a 7-year-old girl. We should be cautious that these patients may develop multiple retinal breaks, and we have to follow them closely to consider laser. This patient landed up in a retinal detachment and underwent a surgery. Can you play the video, please? So here is a retinal detachment, but we usually don't see much PVR in these patients. Here there is PVR, there are membranes. So these patients require good clearance of all the traction, and then the retina has to be settled. As usual, we prefer using 5000 centigrade oil here. You can see multiple breaks. A bimanual dissection is required. Large breaks in the periphery. And multiple membranes. And this can be just continued like a normal retinal detachment surgery. A typical DUSN where you see migrating tracts on the RPE. This was a gnathostoma here in the anterior chamber. So we have a common worm infestation in this age group seen, and we are in a zone where we are endemic for gnathostoma. This first one was the dirophile ariasis. This is a gnathostoma, which is visco-expressed from the anterior chamber. Cysticercosis, which is most common in the subretinal location. Now these patients land up in intense inflammation, so cyst removal has to be done. A retinotomy is made, and this cyst can be removed with a passive suction of a flute needle. The cyst will mold itself through a small opening and can be taken out through the sclerotomy or can be eaten up in the vitreous cavity as well. This is a patient with sympathetic ophthalmitis. Again, we have a series of 20 patients in pediatric age group with sympathetic ophthalmitis. Vitreous hemorrhage patients or vitritis patients, ultrasound is an important tool. The vitritis is dense. The PVD is usually very shallow. The exudates are thick. So they have to be removed, and the vitrectomy should be done with PVD induction as far as in the periphery, so as we don't land up in thick pars plana membranes. They can also have fibrotic complications and traction, which can be relieved during vitrectomy. Again, another rule is to clear the sequelae. Like here, there is a obliterated pupil with partly absorbed cataract. Usually, the cataracts in these patients are calcific and have to be removed through the anterior chamber. These patients can also develop dense fibrotic pupillary membrane, which may require clearance to clear the visual axis. So beyond steroids and immunosuppression, we need systemic monitoring of these patients, intraocular pressure monitoring. We need to check up these children for systemic associations, and retina experts may help in the diagnosis and treatment of these complications. Thank you, and we welcome you to Ocular Trauma Con in Chennai.